On this episode of the ASC Podcast with John Goehle, we discuss the latest news in the ASC industry, celebrate ASC Month, review upcoming ASC Central Conferences, including the 2024 two-day virtual multi-state conference in November, provide more information on the proposed 2025 ASC HOPD payment rule, including the new ASC Quality Reporting proposals, remind listeners of the requirements for malignant hyperthermia drugs, and in our focus segment, discuss cardiology procedures in the ASC setting.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence offers a comprehensive next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com.
Welcome to episode 226 of the ASC Podcast with John Goehle for August 6, 2024. Recording from our studios in Spencerport, New York. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and Operations Manager for Ambulatory Healthcare Strategies. We'd like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of recording. As such, it is important to recognize that this information may be subject to change, and we advise all ASCs to stay up to date with the latest regulations and guidelines issued by their relevant regulatory bodies. Joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry and is a sought-after speaker on regulatory accreditation and finance issues.
Well, we hope everybody is enjoying their summer. Clearly, Sue, you and I are, since we have not had an episode in a couple weeks here, and we apologize. And, of course, when that happens, our news backs up. So we know we've got enough material in front of us right now for 2 episodes. So hopefully we'll get a second episode out in about a week. This is ASC Month. ASCA members, if you're a member of the ASC Association, have access to their toolkit, including state-specific fact sheets, which emphasize the Medicare savings the centers provide, social media post resources, including those nice virtual backgrounds and graphics and information about hosting a facility tour for members of Congress. We really do encourage you to let your local, state, and national representatives know about you. It's always amazing to me, Sue, how many people in government really don't know too much about ambulatory surgery centers. You know, and part of it is because we're not as big as hospitals, and we don't have certainly the money that the hospitals do to kind of get their message out there. But they, the representatives always love doing tours, and especially if there's press coverage with it. So really do encourage you to do that. And Sue, I had the opportunity to do a podcast. I was actually interviewed for a podcast with Doc Buddy, and we're going to include a link to that that episode. It was a lot of fun, Sue. I talked to him for about an hour, and I felt that I could have gone on for another couple hours. They do things very differently than we do. It's a little less structured than what we have, but it was a great episode. And it goes deep into topics like physician engagement, human resources, regulatory and compliance, and the shift to digital. And along the way, I shared some of my stories over the last 35 years in the industry. So we'll provide a link to that, and please visit the Doc Buddy website for more information. And I've been working hard on scheduling a bunch of conferences coming up. You might remember that the ASC Podcast with John Goehle has another website, which is asc-central.com, and that's where all of our conferences are are listed. So in September, we're going to be doing our Infection Control 101 and 201 conferences again. The last time we did it was in September of 2021, and before that was in 2020. So this is something we're committed to updating on a regular basis, and it's going to be September 26th and 27th. So Infection Control 101 will be on the 26th, and 201 will be on the 27th.
It'll be nice to have an updated version of that. That's one of our more popular ones.
It is.
Even the on-demand people request quite often.
Yeah, it actually is. I believe it is our most popular program, second probably to our multi-state conferences. But as we all know, CMS requires both initial training on overseeing an ASC infection control program as well as ongoing training. So Infection Control 101 is designed to help a new infection control coordinator to be prepared for the challenges of developing and running an infection control program, as well as just kind of updating experienced infection control coordinators, because you do have to show ongoing training. And 201 is an expansion. It's more advanced topics and can also help demonstrate ongoing training. So you need to demonstrate both initial training and ongoing training in order to demonstrate to surveyors that you are qualified to oversee an infection control program. And you can also use the 2 days of conferences to help prepare you for the CAPE exam. That's the Certified Ambulatory Infection Preventionist exam. One of those exams that really, I think, is extremely important to demonstrate our commitment to quality in the ASC industry. So for more information about that, go to asc-central.com to sign up. And Sue, we just announced the 2024 Multi-State Conference. It's a virtual conference going to be presented November 14th and 15th, 2024. This is a conference we started in 2023, and we had 5 states. So far in 2024, we have 7 states, and hopefully we'll have more. So right now we have the Colorado Ambulatory Surgery Center Association, the Massachusetts Association of ASCs, the New York State Association of ASCs, the Oregon Ambulatory Surgery Center Association, the Pennsylvania Ambulatory Surgery Association, the Texas Ambulatory Surgery Center Society, and the Virginia Ambulatory Surgery Association. If you're a member of any of those associations, visit their website or contact your association to get a code to be able to sign up for free to the conference. And also, if you're a patron member of the ASC Podcast with John Goehle, you have access to the program as part of your patron membership. And for more information about that, visit asc-central.com or ascpodcast.com.
And if you're a member of an association that hasn't agreed to sponsor the multi-state, then you might want to ask them about it because it's a great opportunity.
Right, and they can reach out to me at info@ascpodcast.com. And one of the reasons that we put this together is, ASC leaders and managers face many challenges in running their ASCs, not the least of which is finding the time and the money to send all of their staff to multiple conferences each year. And we recognize that state associations have limited resources to be able to put on, big conferences now. And we certainly encourage you to attend the state association meetings because you can get a lot of very important and direct information about your state and what's going on in your state. But the multi-state conference is meant to bring together members of all kinds of associations across the country for 2 days of really in-depth conversations. So over a 2-day period, we'll present a variety of topics for both leaders in the ASC industry as well as staff members that deal with these subject areas. Now, while these sessions are going to be presented virtually, recordings of each session will be available after the conference for a period of 6 months. The ASC Central virtual conferences are not your typical webinars. If you've joined any of the ASC Central, ASC Podcast conferences, you know what we're talking about. They're a true conference with ongoing interaction among the presenters and the ability to ask questions in real time. Our virtual conferences are not just educational, but I would say they are entertaining, right? And if worst comes to worst, we just put Rosie, our golden retriever, on the screen and she lightens things up. We also have in the works on November 12th, our Life Safety 101 full-day conference. More to come on that. We don't have any information yet, and the registration hasn't opened. And our next Director of Nursing Boot Camp will be October 22nd through the 25th, 2024. And again, stay tuned for more information or visit asc-central.com regularly for updates on that. Sue, what's going on in the news?
I saw an OR manager that Bausch and Lomb and Synergetics recalled certain packs of IPAC injection kits. They're used to deliver medication to the eye, and after being unable to verify that the products had been fully sterilized, the FDA reported on July 15th that they are being recalled. Obviously, lack of sterilization creates risks including endophthalmitis, vision loss, or total loss of the eye. Yeah. We'll provide a list of the specific lot numbers that they will be recalled, but they're all Bausch and Lomb eye-packed injection kits. And in Becker's ASC review, there was some information about increasing Stark Law violation enforcement, and I just pulled out a few of the items that they talked about. In 2023, CMS settled $12.6 million in Stark Law violations, which was an increase of 552% from 2021. Last year, the most common trends in the Stark Law cases included compensation above fair market value, compensation structures that changed with referrals, and the provision of services to physicians at reduced or no cost, according to a report from law firm Bass, Berry, and Sims. This is something we've talked about before, and again, just reminding you this can be so costly, and it can happen without even realizing necessarily you're doing something wrong. You're just trying to make your place an attractive place for the physicians to be, but you have to be very careful.
Yeah, and we talk about this quite a bit during our legal sections of our boot camps, and this is an area that you really need to get a lawyer involved in. So anytime you're developing compensation packages for owners of the surgery center, you want to make sure that they've been passed through a lawyer to determine that there's no Stark Law issues with regard to that. In particular, the compensation for like the medical director or director of surgical services, et cetera, you want to make sure that that's commiserate with the amount of work that they put into it, not some very large dollar amount that really looks like it's going to be, an inducement for them to bring cases.
Yeah, can't be tied to how much money they make for the center.
That's right, or the number of cases that they perform, as you indicated. So, yeah, definitely something to keep an eye on. We really haven't talked much about Stark until recently, and then it seems to be increasing, and I think there's more enforcement going on.
There is, I think, and much higher fines. So it looks like we might be facing even more supply chain issues soon. I know, John, you had sent me this article. So there has already been a lot of issues on some of the trade routes. But this was HIDA's Daily Clips referenced an article in G Captain about a potential coast-wide strike of the International Longshoremen's Association, or the ILA. They are currently in wage negotiations and are preparing to strike if a new agreement is not reached by the end of September. There's also other issues besides wages that are stalling the agreement, such as the use of autogate systems in some terminals, which would eliminate some of the ILA jobs through automation, which says here it is violating their current agreement. So they're afraid there will be, a lot of people put out of jobs for using these auto gates. And then, as I said, the wages. So that would just add to an already difficult situation.
It doesn't seem like the war situation in the Middle East is going to get any easier anytime soon, which means that this supply chain is going to continue to be a problem here. So. And Sue, we talked about the 2025 payment rule a couple episodes ago. In July of 2024, CMS introduced the proposal for the 2025 HOPD and ASC payment rates. And they have proposed to update the covered procedures list, also known as the CPL, by adding 20 medical and dental surgical procedures to the list, which we discussed previously. But there was no proposal for removing any items from the inpatient-only list for 2025. And what that means is that usually when they come off of the IPO, that gives us an opportunity to start doing them in a surgery center, and that is not occurring this year. The codes that are proposed to be added to the ASC covered procedure list are mostly dental codes. But they do include 4 surgical codes. And I'm going to provide a link to the full payment rule proposal. But if you look at page 574 on that link, there's a table 82, which includes the following HCPCS codes, which are 0717T, 0718T, 0995T, and 0801T. So if you're doing those procedures, you probably know what I'm talking about. If you don't, you probably think I'm just giving you a bunch of numbers. By the way, TPT is a copyright of the American Medical Association. All rights are reserved. So these codes relate to rotator cuff repairs and insertion and removal of permanent dual chamber leadless pacemakers. It should be noted that CMS did not consider the many codes that the ASC Association had recommended, especially in the cardiovascular and spine areas. So that was very disappointing. Now, they have added codes in the past after the proposed rule came out. So
in the comment period.
During the comment period, right. So we're hoping, and I'm sure ASC Association is hoping that they will reconsider some of those new proposals. It just seems odd to me, Sue, that during this time when we're trying to move more and more cases out of the hospital, that we only have 20 codes and 16 of them are dental codes, which the vast majority of surgery centers probably are not going to be doing. Actually, even the 4 codes that were added probably are not going to be in the average surgery center either.
And I think there was a request at one point to at least give some feedback on why certain codes were not being considered, and I don't think that has happened either.
Yeah, I think right now we've just seen a real slowdown. The last 2 years of payment updates have actually been kind of boring, and I think we as an industry would like them to be a little bit more exciting, to have a lot of procedures added as we had seen in some years in the past. Now, the good news, though, is CMS does propose to continue to apply the productivity-adjusted hospital market basket update to the ASC payments. You might remember, if you've been listening to our podcast for years, that in the past they had used the consumer price index for adjusting our fees, and now they've updated it to the hospital market basket, which is much more in line with the types of costs, types of expenses that we have. However, that being said, the increase is really quite minor, about 2.7% this year. I did spend quite a bit of time, as I promised in the previous episode, to talk researching more into the ASC quality reporting requirements. So one thing to remember with the quality reporting requirement is that you have to report these ASC quality measures in order to be able to get your full payment update every year. And the reporting period for 2025, which is part of the proposal, is going to impact your 2027 payments. So if you don't report these items in 2025, then in 2027, your payment rate, the increase in your payment rate will actually be reduced by 2%. So you definitely want to take the time to do all of these or to participate in all of these quality reporting initiatives. So one thing that became quite apparent when we read through this is OAS caps will start January 2025. There has been no change to the plan from 2024. It's actually really not even mentioned other than to say that it will progress as originally planned. So if you have not already started preparing for OAS caps, if you haven't already found a vendor to do your OAS caps reporting, you may wish to do that pretty quickly. I think what's going to happen is we get closer to the end of the year, these vendors, and you have to use an approved CMS vendor, are going to have a hard time setting you up and getting you started in time to meet the January 1st, 2025 deadline. Now, for a full list of the 2025 items, you might want to refer to page 684 of the final rule. But I do want to mention them just to remind everyone of the existing requirements. So first one is ASC 1, which is patient burns, ASC 2, patient falls, ASC 3, wrong site, wrong side, wrong patient, wrong procedure, wrong implant, ASC 4, all-cause hospital transfer admission, ASC 12, facility 7-day risk standardized hospital visit rate after outpatient colonoscopy, and that's reported by the hospitals. So that will be reported directly by the hospitals on your behalf. ASC 13, which is normothermia outcomes. ASC 14, which is unplanned anterior vitrectomies for eye surgery facilities. ASC 15A through E is the OAS caps measures. ASC 17 is hospital visits at the orthopedic ambulatory surgery center procedures, and again, that's reported directly by the hospital to CMS. And ASC 20, which I think we're all disappointed about, the COVID-19 vaccination coverage among healthcare personnel, that will continue through the NHSN portal throughout 2025. I think we had hoped that that's a pretty onerous or very time-consuming reporting requirement, and I thought that we were hopefully beyond that at this point, but they, at least at this point, as part of the proposal, they are continuing that measure. Now, there is one new measure that is being added, and this is going to be completely new for many of you that have never been involved in the hospital, and that is Facility Commitment to Health Equity, or FCHE. This will be a mandatory, if it goes through, a mandatory reporting requirement starting in January 2025. And this measure is based on the existing hospital commitment to health equity measure and will measure an ASC's commitment to using the 5 equity-focused organizational domains, each of which has multiple elements. Now, what you do when you're preparing this measure, you score it. There's a 5-part attestation-based measure, and there's 1 attestation for each domain. And the numerator is the total number of domains in which the ASC is able to attest, up to a maximum of 5. And then, of course, the denominator is the 5. And in order to attest yes to the domain, you must be able to attest yes to all of the elements within that domain. And by the way, I'm going to provide a link for much more information on this, but this is a kind of a dramatic change for ASCs, I think. Here are the domains. I'm going to rotate with Sue on this. So here's the 5 domains. Domain number 1 is the hospital, in this case, the surgery center's commitment to reducing healthcare disparities is strengthened when equity is a key organizational priority.
And domain 2, collecting valid and reliable demographic and social determinant of health data on patients served in a hospital, or as you said, ASC, is an important step in identifying and eliminating health disparities.
And domain 3 is effective data analysis can provide insights into which factors contribute to health disparities and how to respond. And you're going to have to attest to how the ASC engages in those activities.
Domain 4, health disparities are evidence that high-quality care has not been delivered equitably to all patients. Engagement in quality improvement activities can improve quality of care for all patients.
And domain 5 is leaders and staff can improve the capacity to address disparities by demonstrating routine and thorough attention to equity and setting an organizational culture of equity.
It just feels very academic to me.
Yeah.
You know, and so I think it's a great thing to address. I think people, you know, as you're caring for patients, it would be important to check and be sure that they can get any follow-up medication that they need, that they have transportation. You know, asking some key questions, I think, could be really helpful. But this is a lot, and this is almost more trying to identify the issues, and we're not their primary caregivers. So as long as we facilitate their being able to complete their care correctly, you know, whether it means making sure they have a safe place to go home to, or keeping their wound, you know, cared for, and that kind of things if they needed anybody to follow up. But I think most of this can be better served in, you know, hospital or primary care setting.
Yeah, it doesn't seem to me to be very well thought out or really even
or targeted
discussed
at what's going to really help people. So it's not even that I feel like, oh, it's too much work to help people. I'm not sure how. It's just not specific enough or really, you know, targeted enough to make sure they address the real needs that people would have.
Yeah, and I am concerned that, I'm first of all, again, this is a proposal. And again, I'll provide some links for much more information on this if you're interested. And if you think that this is something that really is not within the domain of ambulatory surgery centers, we really encourage you to participate in the comment period and provide your feedback to CMS on this.
Yeah, and all of this takes time. So
that we don't have.
Time better spent doing this, or you know, talking to your patients and figuring out how you can help them, or you know, actually doing the procedures.
Yeah, and I hope that certainly we're talking to the choir. If you're listening to this podcast, you're probably a good corporate citizen and do the best you can to be able to provide, you know, good, high-quality care at a reasonable price to all of our patients, regardless of their economic or social situation. And
encouraging ASCs is actually helping some of this issue, because you're not spending, you know, so much money. The co-pays and the insurances are not having to spend so much money. So
and of course easier access. I would argue that surgery centers are a little easier to access than many of the hospitals are. So I know we probably sound like we're, you know, really down on this, but it just doesn't seem, as Sue said, this is very academic, and it just, you know, we spend all this time talking about our boot camps and our, you know, leadership, and this is yet another thing that's going to be put on the shoulders of administrators and directors of nursing, another responsibility that the governing body is going to have to oversee as part of the governing body meetings and the governing body minutes. So just be prepared for that. I did forget to mention that there are there are a proposed list of qualifying products for separate reimbursement under ancillary services, and these are the non-opioid products. Now, these have been reimbursed, or some of these have been reimbursed in the past, but Exparel, Omidria, Dextenza, Zeracol, I'm sorry if I'm pronouncing these wrong, Zyn, Zynrelef, which is going to be effective April 1st, 2025, Ketorolac, and I'm sorry if I'm mispronouncing these.
Ketorolac.
Okay, Ketorolac. Okay, thank you. That's why I have a nurse here. And then the OnQ pump. All of those, and I'm going to include this in the show notes, all of those will be reimbursable under the ancillary services section for the Medicare reimbursement system in 2025. And as I said, the Zynrelef is going to be effective April 1st and won't be right from the very beginning. So again, don't forget or make sure that your billing people know that those are things that can be billed. I want to talk about a recent experience. We were visiting a center that unfortunately did not have enough Revanto on hand. They had previously used Dantrium, and they had the 36 vials of Dantrium, but when they purchased Revanto, which is another version of Dantrium or an alternative to Dantrium, what is it? They only bought 6 vials of it, I think?
Yeah, one package.
And
this isn't the only time we've seen people not having what they require. They
Right.
either feel like, well, we can get them quickly to a higher level of care, or they just, I think in this case, they just weren't aware. They just bought a package and thought
Right.
that meant they had enough. And they may have mixed it up with Ryanodex, because I know that doesn't take as many, but it's just so important. It's rare to have an MH emergency, but you have to be skilled at it, and you have to have everything you need right there. Very handy.
And really, realistically, too, the outcomes, even when you have all this, are not always good. So you really have to be on top of it. mHaus, which is MHAUS.org, is a great resource for malignant hyperthermia. And they do recommend 36 vials of either Revanto or Dantrium, which has a 3-year shelf life. So you should have 36 vials unexpired in your malignant hyperthermia cart. And when they do expire, we really encourage you to do an MH drill, trying to reconstitute those vials. Sue, I've tried this. I don't think you have. I tried to reconstitute it once. It was a lot of work. I mean, I'm not a nurse, and I have a hard time using needles and things like that anyway, but it was a lot of work.
You need it so quickly. You really have to practice. You have to, all hands on deck that you can get, and just, get it done quickly. So it is important to practice that.
Yeah, and Ryanodex is an alternative. It is more expensive, and it has a 2-year shelf life as compared to a 3-year shelf life. It is a higher concentration. It is easier to use, and you require fewer vials and less sterile water. And I believe that you only have to have 3 vials of this, if I remember right, from the mHaus website. And make sure also that
they've got all that information on mHaus.
And make sure you have the latest poster for mHaus also.
And have it near your cart, wherever you have the medications, and maybe have one right near
in the anesthesia.
Right, wherever, because you want people to recognize the signs very quickly.
Now, we haven't talked about a cardiology, I think, at all on this show. And we thought it would be useful to bring out an interview with Chris DeCarlos on the future of cardiology. He was a speaker at the New York State Association meeting last year. And when I was thinking about cardiology this last week, I thought, let's bring that interview out. We originally used it for the New York State Association's special episode, but it doesn't focus only on New York. So let's take a short break, and when we come back, we'll have a short discussion. And when we come back, we'll have a discussion about cardiology in the ASC setting. With the rapid changes occurring in the ASC industry, the exodus of experienced ASC administrators, nurse managers, and business office managers, there is an increasing demand for quality leadership education. That's where our industry-leading boot camps come in. In 2021, we introduced our administrator boot camp and the director of nursing boot camp, and in 2023, the Business Office Manager Boot Camp. These boot camps have become the industry standard for ASC leadership training, and with over 225 graduates, lead the industry in mentored virtual training.
Live virtual training for the Administrator Boot Camp occurs every January and July, and the Director of Nursing Boot Camp is October and May. Our new Business Office Manager Boot Camp will continue in the spring of 2024. There are also on-demand versions of each boot camp for those who simply can't attend the live virtual programs.
All boot camps, including the on-demand boot camps, include access to resources, membership in the ASC Central Patron Program, copies of John's latest books, access to credentialing, conditions for coverage, and other recorded training programs, and of course our regular drop-in Zoom sessions where you can ask questions and interact with other patron and boot camp members.
Our programs also include AEU credits for those that are CASC certified. Our programs are comprehensive and taught by the nation's leading ASC experts and are designed for all levels of leadership, from experienced leaders who want to enhance their skills or pass the CASC exam, or those who are new to the industry and wish to learn how to run an ASC.
For more information about our live, virtual, and on-demand programs, visit ASC Central at asc-central.com, or you can call us at 585-594-1167 or email us at info@ascpodcast.com for more information. So Medicare reimburses some cardiovascular procedures in ambulatory surgery centers, and for many ASCs, introducing cardiology is very scary. Most ASCs and most ASC staff have very limited or no experience in cardiology procedures, and CMS, or the Centers for Medicare and Medicaid Services, began transitioning cardiovascular procedures to ASC starting in 2019, and the purpose was to reduce the cost of care and save patients money. And so far, there has been some movement. It has not, of course, the pandemic kind of slowed things down a little bit, but it has been a bit of a slow process. And part of the reason for that is not all states actually allow even though CMS allows these cardiology procedures, not all states allow all of these cardiology procedures. So in 2019 and 2020, CMS added coronary procedures to its ASC covered procedure list, the CPL, as we talked about in our first part, which includes diagnostic cardiac catheterizations and low-risk percutaneous coronary intervention, or PCI. Other procedures that are now reimbursed in ASCs include coronary angiography, peripheral arterial disease, electrophysiology, implants, and complex PC. Medicare did remove some cardiology cases from the ASC payable list in 2022, kind of going backwards a little bit. And procedures that are not currently allowed or payable by Medicare to be performed in an ASC setting include leadless pacemaker insertion and/or extraction and cardiac ablations. However, as we talked about in our first segment, they have proposed adding back in the insertion and removal of leadless pacemakers. With the growth of cardiology starting to take off, though, I thought it was a good idea to kind of have this interview that I'm now going to show. Now, Chris DeCarlis is General Manager and Vice President of Procedural Solutions with Image Guided Therapy Group for the Philips organization. And he's responsible for managing customer relationships and providing solutions to office-based laboratories, ASCs, and hospitals. He's a strategic thinker and a strong leader with more than 15 years of experience in the medical device industry. So let's listen to that interview now. I'm here at the 2023 annual New York State Association of Ambulatory Surgery Centers conference in Albany, New York, and I'm sitting here with Chris DeCarlis. Is that pronounced properly?
Yeah, close enough.
Okay,
better than most.
And he's from Philips. And thank you so much for joining us and talking about cardiology and the future of cardiology.
Absolutely. Appreciate you having me.
So when we were talking before we started recording here, I was talking about my time as administrative surgery center, and I ran largely eye surgery centers in those days. And I could not do it without my friends, the vendors in that industry, the Alcon, the Bausch and Lombs, the Zeiss reps, and they became my best friends. They were not just somebody that was selling a product to me. They were, selling a solution.
Sure, absolutely.
And that's what, and right now, cardiology is the hot topic.
Right.
Throughout the country. And here we are in New York State, and it's not allowed.
Right.
And so we just finished talking to Dr. Puma about from a cardiologist standpoint why it should be done.
Sure.
And now, but you have a national perspective. Dr. Puma is from New York. You have a national perspective. So New York is kind of an outlier, right? So talk a little bit about the national perspective on this and what's going on in other parts of the country.
Yeah, sure. So Philips has had an out-of-hospital program since atherectomy was started in office-based labs back in 2010, 2011. Strategically focused on, supporting physicians in their exit from the hospital to office-based labs. And, peripheral vascular procedures, venous procedures, et cetera. Obviously, in 2019, when coronary diagnostics came on the radars for ambulatory surgery center, that made us kind of pick our head up and say, well, what's happening here? Are we going to see a similar shift that we saw in vascular procedures with coronary vascular procedures? And then in 2020, CMS allowed for percutaneous coronary vascular intervention, PCI, to be done in ambulatory surgery centers. And so obviously that piqued a lot of folks' interest. Some folks had built office-based labs that were to ASC standard, sort of sensing that this was coming or having knowledge that this was coming. And for them, it was easy to sort of just flip the switch, call it an ambulatory surgery center, get the certifications and start doing coronary procedures right away. But there's obviously some barriers to that, right? Like we talk about New York State, it's not currently allowed. But what we're seeing across the country is that those states, particularly obviously in the South, where there were no restrictions or laws against coronary procedures being done in ambulatory surgery centers, we saw really an explosion. Yeah. And we're continuing to see that mostly in the private physician management company, private equity. But we are starting to see the hospital and IDN shift into the cardiovascular ASC as well. The other thing that's interesting is we're seeing these states that previously had laws on the books, like Pennsylvania, South Carolina, shift towards allowing these procedures to be done in the ambulatory surgery center as well. So as we're always planning 3 to 5 years out, we do see more and more states allowing cardiovascular procedures to be done in the ambulatory surgery center site of service. And the other thing that we see is more complex procedures moving towards ambulatory surgery centers over time. Obviously, safe procedures that can be done effectively. And for us, at Philips, it's all about the patient, right? And ensuring that we're really helping them, achieve their goals, getting back to living a healthier, happier life. Obviously, we know in an ASC, lower copays, right? So lower cost of care. So for patients, they love that. They love going to this site versus a hospital and having the procedure done and being sent home, within hours of stepping foot in the facility. Obviously, we know lower infection risk in an ambulatory surgery center than in a hospital. So, we know we can have safer outcomes from that perspective, and that's really what we're focused on is lowering the cost of care, helping our patients achieve better outcomes at a lower cost, and that's why we're so interested in this movement, this shift of cardiovascular procedures into the ambulatory surgery center.
Yeah. So ambulatory healthcare strategies works in Pennsylvania and New York, many other states too. But I think I was shocked when Pennsylvania allowed it before New York did, because if you talk about a state that their CON regulations are not as strict as New York is, but your ability to add new procedures is definitely much tougher, and and the fact that they've gone in that direction seems surprising to me. What do you think are the barriers in New York? From your experience, have you had any opportunity to look into that? I know you're very active right now in trying to get New York to recognize the value of this.
Yeah, well, I know. Look, New York, it's the Mecca, right? It's so many teaching hospitals, fellowship programs there as well. So, obviously, the hospitals are very big, very, very powerful in New York. That could play in to some of what's happening here. But what I would say is, as PCI first started to shift into ASC, we heard many people in many different states say, That will never happen.
Yeah, right.
Right. My state would never allow this. You
kind of what happened with total joints. We're never going to be doing total hips in surgery centers. Now they're routine.
Yeah, exactly. Yeah. Absolutely. But again, we see this shift occurring. And we do believe that in a majority of the states that are currently, there's laws in the books or certificate of need is such a high barrier that folks are even today saying, well, that may never happen. Massachusetts, California, et cetera. We do see over time PCI shifting even in those states which are probably most reluctant to or will be one of the last to allow this procedure to be done.
So, Chris, talk to my audience who is sitting there saying, I've been doing eye surgery for years. I've been doing GI procedures for years. I've been doing arthroscopies for years.
Yeah, sure.
I've never touched a heart. I don't want to be anywhere close to that. That's got to be scary, to me. What type of barriers? Now, the first thing I'd say is, obviously there's a lot of support out there. This is being done out there. But, what is your answer to that? Speaking from a vendor standpoint, and the support that would be provided to them.
Sure. Well, what we've seen in ambulatory surgery centers in a similar situation do is just bring in a coronary C-arm, a cardiac C-arm, and start to do some very basic CRM procedures, like pacemakers or battery changes, right? Yeah. That way you don't have to dive into the deep end of the pool, right? You're just dipping your toes in to see, is there a physician who can come and do those procedures? Is the referral network robust enough, right?
Yeah.
And then you can decide, is it worth the investment, right? Because we know converting an existing operating room to a cardiovascular lab, not even counting equipment, is going to be close to $1 million, right? And then obviously all the devices you'll need to bring in to support those PCI procedures. And most companies will consign a majority of those products, but you will have to purchase some devices as well. I think there's ways to sort of lower the barrier and start small and grow into that facility where you're doing PCI and you're equipped to do the future cardiovascular procedures. But I mean, we do know that cardiovascular is the fastest growing ASC specialty today. And we do know that the payers, United Health says that a shift of cardiovascular procedures to the ASC will save the healthcare system 59% from an expense perspective, right? So we know the payers are very interested in these procedures shifting.
And Medicare recognizes that. They're already starting that process. If Medicare, if we can save the Medicare program that money, you can imagine what can happen with the private insurance.
Absolutely.
Yeah.
I get that it can be a very daunting. I've never touched a heart, and it's scary. Yeah. Obviously, you refer to physicians for their thoughts there, but I think obviously you're going to take your safe procedures there initially. You're not going to be doing complex PCI. You're certainly not going to be taking call and bringing in heart attacks right into your cardiovascular ASC. That's just going to be reserved for the hospital. But obviously we do see this shift occurring broadly across the country. And listen, even in the states where it's wide open, there's still some provider hesitancy, right? We still have some physicians that are unsure whether this shift to the ASC, whether they should take part in it. But by and large, particularly the independent cardiologists have really started to lead this movement. And we are starting to see IDN and hospital engagement as well. And so that's starting to pick up as we sort of anticipated it would. And we anticipate seeing more and more of that over the next few years.
Now, it's scary, $1 million price tag for the equipment. But the financing of that's probably that's a barrier you can get over relatively easy, as long as you have a strong financial plan. Christy is also with us. She's off microphone, but we were talking about feasibility studies, which are so important, in order to determine that, financially this is viable, and it will be viable. There's no doubt about it. But speaking as a former administrator and now working with a lot of administrators, and as a finance guy, I can get past the problem of financing all of your wonderful equipment. But what scares me is what am I going to have to do with my operating room? How long am I going to be down? What's going to be involved in the infrastructure there? Can you talk a little bit about that and what would be involved in, let's say, we've been talking a little bit about eye surgery, for example, moving out of ambulatory surgery centers in the next couple of years. This is an alternative here. What would it take to assuming that you've got a properly sized room in the first place.
So ACC is calling for a minimum 600 square foot room.
Okay, so that is much bigger room.
It's a bigger room than there is.
Because of the equipment that you're putting in there.
Yeah. Right, you have your four different sections and you need the space for the equipment.
Okay.
You're going to have a large C-arm in the room. You're either going to choose ceiling mount or floor mount. That's really physician preference. Most often we're seeing ceiling mounted systems. So you're going to need rails in the ceiling. Yeah. You're going to need radiation shields, lights in the ceiling, et cetera. You're going to need to have a control room, so a separate room where you're doing your monitoring with a leaded window, leaded walls, so that radiation is not escaping that room. About 120 square foot there. Okay. And then you're going to need a room for your equipment, essentially the guts of the equipment, your servers, et cetera, about another 120 square foot room for that as well. And so, when I talk about, $1 million not counting equipment, that's really what I'm referring to, converting that existing operating room to a cardiovascular operating room.
And it's likely you're only going to need one for the average surgery center. Is that true? Unless you're a super high volume. And
de novo cardiovascular ASCs, what we're seeing happen most often is they're hanging one fixed system in one room, and they're building the second room with the technology to do that in the future, but they have a cardiac C-arm in there, and that's where they're doing their CRM, waiting for more complex PCI procedures to come or looking at their volume. But yes, existing ambulatory surgery centers that are adding a CV service line, we're seeing one room. But to your point, during construction, that room is down. You can't use it to do your other procedures. And so that does create a challenge. And I think that's where you guys come in and can show sort of cost benefit analysis to say, hey, you're down for this long, but here's what this looks like once we're open, right?
Right. And I think as as all of us are contemplating the future of certain procedures that might be moving in, the opposite direction yours are, moving into the OBS environment.
Sure.
We're going to have to make structural changes. We're going to be going through construction. We might be expanding for that matter, or we might be contemplating building a new surgery center for multi-specialty. Sure. I think your message is very important. Even if you don't think you're going to be doing cardiology now, build that 600 square foot room, have that extra, I think I just added up 240 square foot for a possible future control room and storage or equipment room. So that, because the cost now to add that is going to be far less than the cost is going to be to retrofit an existing center down the road. So think about it.
And it boils even down to parking, right?
Good point.
Do you have enough parking spots per the requirements, right? Yeah. So oftentimes when an ambulatory surgery center adds a cardiovascular service line, they need to add parking to their facility. And if you can't do that, that creates a barrier there as well.
Especially with local codes, we usually demand a certain amount of code spaces based upon the size and the clients that are coming through.
Absolutely. So those are some of the challenges. Obviously, HVAC, stainless steel HVAC. All of those different things that might be different than when that ASC was originally built and having to now go back and retrofit the space. So, but there's experts obviously, and we obviously point to those experts when our customers are coming to us and thinking about that service line. Is there's experts in the room that can do an analysis for you and walk you through the process and what those next steps might look like.
So the future is upon us. Now New York isn't yet there, and you're working. Thank you very much for working on behalf of the industry to get this over the finish line there. But for those of you that might be listening from other parts of the country, it's time already in many of these states. So start thinking about it, and Medicare will continue to add additional procedures to that list that can be done.
Absolutely. It wasn't more than 24 months ago, I sat on a panel where we were asking, has the boat left the dock yet, right, on the shift of cardiovascular to the ASC? I think the question we're asking now is, is it a sailboat or is it a speedboat?
Yeah, that's
right.
Yeah.
And so I think time will tell.
Yeah.
But we're certainly starting to see signs in the market that are encouraging from a shift out of hospital to ambulatory surgery center perspective. It appears as though the shift is happening and ramping up as we speak.
And we need to be prepared to be able to deal with that.
Yeah, that's right.
I appreciate it so much, Chris.
Yeah,
Thanks for joining us.
Thank you so much. I appreciate it.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
The Georgia Society of ASCs and the South Carolina ASC Association's joint semi-annual conference and trade show is August 15th and 16th in 2024 in Hilton Head, South Carolina at the Marriott Hilton Head Resort and Spa. And Lori Rodericks will be speaking at that conference.
The 2024 Illinois Association of Ambulatory Surgery Centers annual meeting, it will be held August 22nd and 23rd, 2024 at the Crowne Plaza Chicago O'Hare Hotel in Rosemont, Illinois. John is doing an ASC Administrators Workshop there. That'll be a 4-hour workshop.
Yeah, so I'm looking forward to it. I think I better get the slides prepared for that. I think I'm a little bit behind there. And the California Ambulatory Surgery Association's annual conference is September 4th through the 6th in Anaheim, California at the Anaheim Marriott. We're still not sure whether we're going, or I should say I'm not sure if I'm going to that conference. We're still trying to work that out.
The Tennessee Ambulatory Surgery Center Association's annual conference is September 12th and 13th in Chattanooga, Tennessee at the Chattanoogan.
And the New York State Association of Ambulatory Surgery Centers annual conference is September 17th and 18th at the Desmond Hotel in Albany, New York. And Ambulatory Healthcare Strategies will be doing a pre-conference, which is 3 hours of education. That's going to be on Monday the 16th. And if you are a client of Ambulatory Healthcare Strategies in New York State, there's also a meeting of all of our New York State clients at the Desmond on the morning of the 16th.
The Becker's ASC 30th Annual Meeting, the Business and Operations of ASCs, is October 30th through November 2nd in Chicago, Illinois at the Hyatt Regency.
And the Washington Ambulatory Surgery Center Association's 2024 Annual Education Conference and Trade Show will be November 7th and 8th, 2024 at the Tulalip Resort and Spa in Tulalip, Washington. And I will be speaking about accreditation and provide an update on accreditation trends. I do want to remind you that there are on-demand versions of our ASC Director of Nursing, the ASC Administrators, and the Business Office Managers Boot Camps, and they're all available on our sister website at asc-central.com. And we also do want to encourage you to become a patron member of our podcast. The patron member program, which is available on asc-central.com, is an exclusive membership website that provides a one-stop ASC regulatory and accreditation, compliance, operations, and financial management resource for busy administrators, nurse managers, and business office managers. And in addition to our pretty well-known, regular, usually weekly drop-in Zoom sessions on Saturday mornings with other patron members and the staff of the podcast, we also have additional patron resources, which include some of our virtual conferences, such as our credentialing conference, the Conditions for Coverage conference, and the multi-state conferences. And we also have example policies and procedures, example forms, and our famous fire and disaster drill kits. Membership helps defray the costs of producing this podcast, including research staff, travel costs to conferences, equipment costs, and production costs. For more information, visit asc-central.com. And I want to thank you for joining us for this episode of the ASC Podcast with John Goehle. If you found this episode informative, we encourage you to share it with your friends and colleagues in the ASC industry. And don't forget to hit that subscribe button so you don't miss a single episode of our show. We would love any feedback about our episodes and ideas for future episodes by sending us an email at comments@ascpodcast.com.
We'd like to give a special thank you to our great team here who make this podcast possible. Our sound editor, Susan Cronkite, our executive producer, John Goehle, and our dedicated research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Alex Borneman, Zach Kaloritis, Jim Masters, Amy Cronkite, Lori Rodericks, Kathy Fody, Donna Macchio, and Christina Norman. We couldn't do it without them. Our music is provided by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast platforms. Thank you for listening.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, providing cutting-edge information solutions for surgery providers. Trivalence, offering a comprehensive and next-generation ASC solution that optimizes payment and supply chain performance, enabling actionable data insights. MedServe, which offers the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies, which is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For information about any of our sponsors, please visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. And we'd love to hear your questions and comments. Please email us at comments@ascpodcast.com.